Suicide is officially the 11th leading cause of death in the United States, and most epidemiologists agree that the actual numbers of suicides may be 2 to 3 times higher than what is reported. Many of these unreported suicides occur when people deliberately drive into a bridge or off a cliff. Around the world, suicide causes more deaths per year than homicide or HIV/AIDS. Suicide is overwhelmingly a white phenomenon. Most minority groups, including African Americans and Hispanics, seldom resort to this desperate alternative, as we can see in this figure. However, the incidence of depression in Native Americans is extremely high, and their suicide rate is also extremely high, far outstripping the rate in other ethnic groups. There is some evidence that there is a great deal of variability across the various tribes. Even more alarming is the dramatic increase in death by suicide beginning in adolescence. In the United States, rates of death by suicide per 100,000 people rise from 1.29 in the 10 to 14 age group to 12.35 in the 20 to 24-year-old age group. For teenagers, suicide was the third leading cause of death behind unintentional injury such as motor vehicle accidents and homicide in 2007. The great sociologist Emile Durkheim defined a number of suicide types based on the social or cultural conditions in which they occurred. One type is formalized suicides that were approved of, such as the ancient custom of harikari in Japan, in which an individual who brought dishonor to himself or his family was expected to impale himself on a sword. Durkheim referred to this as altruistic suicide. He also recognized the loss of social supports as an important provocation for suicide. He called this egoistic suicide. That is, older adults who kill themselves after losing touch with their friends or family. It has been found that only 13% of the 75 individuals who had seriously attempted suicide had an adequate social network of friends and relationships. Anomic suicides are the result of marked disruptions, such as the sudden loss of a high-prestige job. Finally, fatalistic suicides result from a loss of control over one's own destiny. The mass suicide of 39 Heaven's Gate cult members in 1997 is an example of this type because the lives of those people were largely in the hands of Marshall Applewhite, a supreme and charismatic leader. If a family member has committed suicide, there is an increased risk that someone else in the family will also. Offspring of family members who had attempted suicide had 6 times the risk of suicide attempts compared to offspring of non-attempters. If a sibling was also a suicide attempter, the risk increased even more. A variety of evidence suggests that low levels of serotonin may be associated with suicide and with violent suicide attempts. More than 80% of people who kill themselves suffer from a psychological disorder, usually mood, substance abuse, or impulse control disorders. Suicide is often associated with mood disorders, and for good reason. As many as 60% of suicides, 75% of adolescent suicides, are associated with an existing mood disorder. But many people with mood disorders do not attempt suicide. And conversely, many people who attempt suicide do not have a mood disorder. Therefore, depression and suicide, although strongly related, are still independent. Looking more closely at the relationship of mood disorder and suicide, some investigators have isolated hopelessness, a specific component of depression, as strongly predicting suicide. Alcohol use and abuse are associated with approximately 25 to 50% of suicides and are particularly evident in adolescent suicides. Combinations of disorders, such as substance abuse and mood disorders in adults, or mood disorders and conduct disorders in children and adolescents, seem to create a stronger vulnerability than any one disorder alone. Past suicide attempts are another strong risk factor and must be taken seriously. One set of researchers followed almost 8,000 individuals who were treated in the emergency room for deliberate self-harm for up to 4 years. 60 of these people had killed themselves, which is 30 times the risk compared to population statistics. Perhaps the most important risk factor for suicide is a severe, stressful event experienced as shameful or humiliating, such as failure, real or imagined, in school or at work, an unexpected arrest, or rejection by a loved one. Physical and sexual abuse are also important sources of stress. Evidence confirms that the stress and disruption of natural disasters increases the likelihood of suicide. Given pre-existing vulnerabilities, including psychological disorders, traits or impulsiveness, and lack of social support, a stressful event can often put a person over the edge. An integrated threshold model for suicidal behavior incorporates various predisposing factors and precipitating factors that increase the risk, as well as a group of protective factors which decreases the risk of suicidal behavior. The Suicide Prevention Resource Center, a federally supported resource center for suicide prevention, makes a distinction between screening and assessment in their discussion of approaches to evaluating suicide risk. There is a link on the course page to their publication that provides guidance for clinicians in the selection of a suicide screening or assessment instrument or program. It provides links to a variety of other resources for you to choose from, depending on the population you are planning to screen or assess. Remember that item 11 on the level 1 symptom measure is thoughts of actually hurting yourself, and that further inquiry is indicated if the client circles anything but 0. Whatever system you choose to assess suicidality, it should include some version of a direct question. Are you thinking about suicide? I encourage you to ask every client you are assessing some version of this question verbally, whether or not you are using the level 1 measure. While there are many different ways to ask this question, there's only one wrong way. If you ask, "You're not thinking about suicide, are you?" you communicate your discomfort with the topic and invite the client to deny any thoughts they might be having. I encourage you to develop a script for this question and actually rehearse saying the words a few times as a means of reducing your anxiety. When you feel like your client is at risk of suicide, the next step is a constructive safety plan. I prefer something in writing and having the client sign it. I don't know if this really increases the likelihood that the client will follow through on the plan, but I like the feeling of us agreeing on the plan. On the course page, there is a therapist guide to safety plans, which includes a model safety plan. If you are working at an agency, I encourage you to review their policies and procedures about suicidal clients and advocate for a safety plan form if they don't have one.